Hi, and welcome to the final geriatric lecture series of 2019. I'm Ryan Carnahan. I'm a psychiatric pharmacist and epidemiologist at the University of Iowa College of Public Health in the Department of Epidemiology. I am a researcher, and I've focused my research on medication safety and use in older adults. I've spent about the last 10 years largely focused on de-prescribing of antipsychotics in dementia and trying to ensure appropriate use. So this is something that I feel very passionate about, something that I'm glad to be talking with you about today. I'm also going to be talking about de-prescribing in other conditions, however, most of them, of course, related to psychiatric types of conditions. I don't have any real significant conflicts of interest. I do have a family member who provides psychotherapy services, and I'll be talking a little bit about psychotherapy. And antipsychotics are FDA approved for some of the indications that I'm going to talk about today, but for most of them, antipsychotics are not approved, so I want to make that clear. Today we're going to discuss the rationale for decreasing antipsychotic doses or discontinuing antipsychotics in older adults, discuss the risks and benefits of antipsychotics, identify candidates for gradual dose reduction or discontinuation, and describe approaches to gradual dose reduction and discontinuation of antipsychotics. So hopefully by the end of this talk you'll feel comfortable with a number of these topics. Antipsychotic use is very common in older adults, and that's one of the reasons why I think talk about de-prescribing is very important. In 2007 and 2008, there was an estimate that almost 3.5 million physician visits involved antipsychotic prescribing, and 3/4 of this was for off-label conditions, things other than the things that antipsychotics are generally considered appropriate for. About 2/3 of use was for off-label conditions where benefit is uncertain, so things where we really don't know if antipsychotics are the best option. So there's a lot of use out there that's just for various different types of conditions, and we don't know necessarily as much as we'd like to know about how well these drugs work. Reasons for antipsychotic use in older adults are very broad. There are many of them. Some are perfectly good reasons. Some are maybe not so good reasons. We have our FDA-approved indications. All antipsychotics are basically approved for schizophrenia. Many are approved for schizoaffective disorder and bipolar disorder as well. A few antipsychotics are approved for adjunctive treatment of major depressive disorder. So these are very common. Depression is, of course, a very common mental health condition, and although antipsychotics are not first line, they are sometimes used for that condition. We also have other psychotic disorders like delusional disorder, and then dementia symptoms, which actually accounts for a great deal of the antipsychotic use in older adults, as do delirium symptoms, particularly for hospitalized patients. We also have some indications where antipsychotics are pretty heavy hitters to be using in some of these. We have anxiety disorders. A lot of people seem to be using certain antipsychotics for insomnia. Acute agitation, of course, is a very common place for use, and other things. There are too many topics really to try to cover them all today. So I'm going to focus on some of those topics where antipsychotics are most often used and where we really want to think about can we reduce the dose, or can we get rid of this drug in this condition? So antipsychotics have a variety of side effects, and these are reasons that we have to be very careful about the use of these medications. They cause sedation as well as postural hypotension, which can lead to falls, and falls are the number one cause of injury in older adults, and really lead to a lot of decline and other problems. Mortality is high after things like hip fractures. So things that cause falls are things that we really try to avoid in older adults when we can. They also cause extrapyramidal symptoms or movement disorders. So Parkinsonism is very common, where people get rigid. Maybe they have swallowing difficulties, which can lead to aspiration, as well as some other extrapyramidal side effects. And tardive dyskinesia. Tardive dyskinesia is actually a chronic, possibly irreversible movement disorder. So even if you take the antipsychotic away, that's not necessarily going to go away, and older adults are at higher risk. Sometimes when you take an antipsychotic away, the tardive dyskinesia can actually get worse. So this is something that we want to avoid, and a good reason to try to avoid chronic use of antipsychotics in older adults when we can. Studies in dementia have showed us that there is an increased risk of stroke, about a 1% increased risk of experiencing stroke in antipsychotic users in dementia. And similarly, we have about a 1% increase in mortality in randomized controlled trials of antipsychotics used for dementia symptoms. Most of that mortality is due to infectious or cardiac reasons, and those are the reasons that people with dementia are most likely to die, but there are reasons to believe that antipsychotics can cause those things. So for infection, antipsychotics may cause, as I mentioned, swallowing difficulties, and that can lead to aspiration, pneumonia. Pneumonia is a very common cause of death. There may also be some things that they do with respect to the immune system that we don't understand that well. And they can cause cardiac conduction difficulties, which can lead to sudden death and other cardiac problems, as well as potentially falls. So all these things kind of come together in some ways. Metabolic side effects are also a major issue, especially given the prevalence of obesity and metabolic syndrome types of conditions in older adults. Antipsychotics can cause a lot of weight gain. They can cause increased blood glucose and diabetes. They can cause hyperlipidemia. So particularly for people with these conditions already, giving an antipsychotic may cause them to be worse, and we need to try to manage those side effects or prevent them when possible. There are other side effects. They're not even all listed here, but a number of antipsychotics have been related to urinary types of side effects, and some can cause constipation, which can actually be pretty significant in older adults, and those are particularly the anticholinergic antipsychotics. It's a particular pharmacologic effect of these drugs that leads to things like constipation, dry mouth, and that would include clozapine, quetiapine, olanzapine, and a number of the first-generation antipsychotics, particularly the low-potency drugs, have those effects. There are many questions we might ask when we're considering de-prescribing of antipsychotics. And these are the same types of questions oftentimes that we ask when we're considering de-prescribing of any medication. First off, is the reason for use appropriate? Should we be using this medication at all for the condition it's being used for? Did the drug appear effective? And this can sometimes be a hard question to answer, because sometimes people get better, and sometimes it's due to a medication, and sometimes it's due to just getting better. And that can be particularly true in conditions that fluctuate or resolve over time. Things like delirium, where you have, they get acutely confused, and then they may have some symptoms, agitation that requires or would benefit from use of an antipsychotic, but then when they get medically well, they can get better. And even other types of symptoms in dementia have a high placebo response rate, so just because somebody gets better when you give them a drug doesn't mean that it's the drug that's causing that. Is this the minimum necessary dose for the patient, and how do we know that? So I'm going to be a proponent in this talk of gradual dose reductions. I know sometimes people are scared to do gradual dose reductions because they're afraid that symptoms might come back, people might become derailed. But in many cases, people are on doses that are higher than what they need, and the evidence would suggest that many times we can be successful in reducing the dose. I don't think we have to be overly aggressive in cutting back on the dose to try to find the right dose, perhaps unless somebody is experiencing a lot of adverse effects, but there are many reasons to think that trying gradual dose reductions is a good idea for many different types of indications. Is the patient experiencing side effects is always an important question. Antipsychotic side effects tend to be dose dependent, and so if somebody's having side effects, then we may want to consider cutting back on that dose or changing to a different drug and trying to reduce the side effect burden. And then the big question oftentimes is there a safer or more effective treatment option? So for many of the things that antipsychotics are used for, we can consider psychotherapy or different types of non-drug behavioral interventions that may be helpful for people. And there may be other drugs as well. So we always want to think about, is there something else we can be doing before we use a risky drug to try to manage a patient's condition? Next, I'm going to move into just talking about some particular conditions and kind of some of the issues you might consider when looking at antipsychotic use in those conditions, and whether discontinuation or a dose reduction may be appropriate. I'll start off with the real common FDA-approved indications where we usually consider antipsychotics to be appropriate. They're really the mainstay of treatment for schizophrenia and schizoaffective disorder. In bipolar disorder, they're often used. We do have other drugs like lithium and other types of mood-stabilizing drugs that can also be helpful, but a lot of people end up on antipsychotics. That said, the doses that people are taking may still be too high, and that comes with an additional side effect burden. There are changes, as we've talked about in prior lectures, in the pharmacokinetics and pharmacodynamics of drugs. As people get older, they may eliminate them from their body more slowly. They may affect the body in different ways. And so just because somebody's been on a drug at some dose for 20 years doesn't mean that that's necessarily the right dose for them as they get older. And that applies really to many different types of medications. And there can also be aggressive initial titration, where somebody comes into the hospital maybe with an acute psychotic episode, and they're trying to get them well, get them out of the hospital, and so they're going to be pushing up that antipsychotic dose sometimes pretty quickly in hopes that they can get a faster response. Just because that's the dose that they ended up on when they were in their hospitalization does not mean that that's the best dose for them long term. It may be possible to cut back on that dose as symptoms start to resolve, and they may be stabilized on a dose that's lower than that, which will lead to reduced adverse effect burden. I do think it's important to be cautious in thinking about cutting back on antipsychotics in these conditions, and there are many people who we think, well, this is probably the right dose for them and we don't want to cut it back. But when we actually look at studies of older adults, we can see that many can be successful in reducing the dose of the antipsychotic that they're taking. Some studies have targeted around 60% of the original dose, and while not everyone is able to get to that point, many patients were able to get down to that lower dose without any real adverse impact on their symptoms. Again, these adverse effects are dose dependent, so if we can get down to a lower dose, especially in older adults who are more sensitive to many of the adverse effects, then people may end up doing better. And there are also those issues around, just because someone needed this when they were 20 years ago doesn't mean they need it now. Can have to do with the way that their condition changes over time. So for a lot of different reasons, symptoms sometimes lessen in older age, particularly in schizophrenia. And they may just need less antipsychotic than they needed at younger ages. That may be because there is less substance use or other types of issues that lead to that. So I do think that in many cases we can consider gradual dose reductions for people with these conditions, even though they're FDA approved and really entirely appropriate conditions. Some of those studies have looked at 25% dose reduction per month. I would consider that fairly aggressive unless somebody's starting off maybe on a pretty high dose, so we don't necessarily have to push the dose down that quickly. If they're not experiencing side effects, then a relatively slow downward titration can be fine. And we have to pay careful attention to the symptoms and functional outcomes. So this is generally going to be done in collaboration with a patient's psychiatrist. Major depressive disorder is another, as I mentioned, common mental health condition that many people experience that antipsychotics that a few antipsychotics are FDA approved for. And that's really for adjunctive treatment of depression or treatment-resistant depression, cases where the people are not responding to SSRI antidepressants, for example. The studies that have been done of antipsychotics in depression were done largely in younger adults, so the mean age in those studies was around 45. We don't know quite as much about what happens when you give an antipsychotic for depression in an older adult, although there's been some work looking at that. Those studies that were done for depression, there was a meta-analysis of those done recently where they pool all those studies together, and they found that the number needed to treat for remission was 19 with olanzapine and 9 with other drugs. Now, admittedly, remission is a very difficult outcome to achieve in major depressive disorder sometimes. A lot of people can respond and have a reduction in symptoms, but getting to full remission can be difficult. But they also suggested that there were no to small benefits on quality of life or other functional outcomes with these medications. So they're not wonder drugs necessarily for depression. They may lessen some symptoms, lessen the severity of the emotions people are feeling, but they're not necessarily going to be something that you want to use often or that you want to leave somebody on forever. There was this open label study in late life depression that just kind of looked at how are antipsychotics being used in in older adults with depression. And most of the use was quetiapine and aripiprazole. And they found a 66% dropout rate. So 2/3 of patients dropped out and basically didn't want to continue taking this medication due to side effects or possibly other reasons. But there were a lot of side effects experienced with quetiapine. Sedation was very common, for example, dry mouth. And with aripiprazole, people experienced a lot of akathisia, which is a restlessness, which that people feel, the inability to sit still. And this can be problematic in that sometimes it looks like agitation and people don't necessarily recognize it. It's a common side effect with aripiprazole, probably more common than with some of the other antipsychotics. So in thinking about long-term use, we also know that depression often involves acute episodes and that symptoms can resolve over time. So if somebody's severely depressed and you're trying to get a response with maybe an antipsychotic augmentation, could be something to do, but it doesn't mean that they need to be on that drug for years. They haven't really been looked at for long-term maintenance so much, certainly not in older people. And given that we know they cause a lot of side effects, if you can manage someone with antidepressants and with psychotherapy and with other approaches, then getting them off the antipsychotic after you sort of manage the severe acute situation may be a good idea. So generalized anxiety disorder is a condition where people are really just anxious about a lot of different things. And there are a lot of different ways that we can try to manage that. Psychotherapy is safe and effective in older adults. Some people may not think older adults want to engage in that, but it has been studied and shown to be effective for a lot of different conditions, even in older adults. And there are a lot of other things we can do for generalized anxiety disorder: meditation, yoga, breathing exercises, relaxation tapes or recordings or other things. So there are many ways to try to manage it. SSRI antidepressants, or any antidepressant really, can also be an effective treatment for generalized anxiety disorder. And so those are probably going to be first line in most cases where you need to move to a drug. We do try to avoid things like benzodiazepines in older adults when possible due to the risks of falls and cognitive impairment. Quetiapine in particular, the extended release version, did show some benefit for generalized anxiety disorder in a large randomized placebo-controlled trial in older adults. But a lot of them also experience side effects. So somnolence is a synonym for sleepiness. About a quarter of people experience that. 17% dry mouth, consistent with the anticholinergic and antihistaminic effects of quetiapine. There were nausea, and there were actually a few cases of extrapyramidal side effects. Quetiapine doesn't usually cause a lot of extrapyramidal side effects because it doesn't bind dopamine receptors too strongly, but there did appear to be a few more cases in the drug group than the placebo group in this study. Side effects also became more common as people got older. So in those 75 years plus, they were more common than in those under 75 years old. So again, people are more sensitive to those side effects as they get older. So my big concern really about quetiapine in particular, as well as some of the other antipsychotics, but it has anticholinergic effects and these sedating antihistaminic effects. So anticholinergic effects cause cognitive impairment. They cause constipation, dry mouth, other things I've mentioned. And this general effect of this drug being sedating can lead to risk of falls. And so I'm concerned about the side effects of this drug. And so even if it is effective in this condition, I would definitely recommend other treatments before considering quetiapine, and then also considering adjunctive psychotherapy. And that would be either just for management or to support dose reduction and discontinuation. So oftentimes when we decide, maybe when we want to try to discontinue a particular drug in a patient, I think it's always a good idea to think about, is there something else that we should do to help support them in that? Rather than just taking the one thing away, is there something new that can replace it? Maybe a non-drug type of management strategy. And psychotherapy can be a good one, or some of the other things that I mentioned. Insomnia is one of the more suspect indications for antipsychotics. There's actually a group, deprescribing.org, or they can be found at that website out of Canada, that's done a lot of work on deprescribing of different medications. And when they talk about, in their decision tree for deprescribing of antipsychotics, they basically say if this is for insomnia, you should stop it without really any sort of additional considerations. So as with generalized anxiety disorder, that which can come along with insomnia, as can depression and other things, psychotherapy is an effective and safe treatment for insomnia in older adults. There are also other things that we would want to consider: sleep hygiene approaches, making sure people aren't watching TV in bed, drinking coffee late in the day, laying in bed for hours, not being able to fall asleep. And so there are usual sort of sleep hygiene strategies we can think about. And then all those other things I mentioned for anxiety may also be helpful for insomnia: relaxation, meditation, other types of things. So we don't know a lot about quetiapine use for insomnia. There are not really good studies showing us whether it works. We do know it's sedating, so it's not surprising to me that it would put somebody to sleep. But there's certainly enough evidence to know that it's probably being used off-label at low doses for insomnia in a lot of different places. Now, another thing that concerns me about it, I mentioned that it has these antihistaminic, anticholinergic effects. And when I look at the low doses that are used and the pharmacology of this drug, I really think that those might be the predominant effects at the low doses. And it really, as I mentioned, doesn't bind dopamine very strongly like a lot of other antipsychotics. So the drug starts to look to me a lot like diphenhydramine or Benadryl or other first-generation antihistamines. All of these are considered high-risk medications in older adults because of the risks of falls and cognitive impairment. So we try to avoid using those things for insomnia in older adults, things like Tylenol PM, which has these drugs in it. And then, even that aside, the cost of quetiapine relative to a lot of other treatments is quite high. So it's something that I think is not a very good idea to be using this drug with all its potential side effects for insomnia in older adults. There are, in fact, admittedly, few drugs that are considered safe and effective for management of insomnia in older people, because many of them are sedating, which leads to the risk of falls. So that is somewhat of a challenge, but is this a good replacement? I have my strong doubts. So low-dose quetiapine can probably be discontinued quickly or immediately. If somebody's on 25 milligrams, for example, I don't think you need to taper that down in most people. If they're on 50 or higher, then you could consider a slow or even a fairly quick taper of this drug to avoid the possibility of withdrawal symptoms. So anticholinergic drugs in general can produce withdrawal symptoms like upset stomach, a little bit of diarrhea, maybe some trouble sleeping, some other things. So tapering that dose down, if feasible, isn't a bad idea. So now we're going to move on to some conditions where antipsychotics are very commonly used in older adults, and one of those is delirium. And we know that first-line management of delirium involves non-drug interventions and addressing underlying medical causes. So those non-drug interventions can be things like orientation, cognitive stimulation, trying to make sure people are hydrated, have things to drink, make sure that they have their glasses and hearing aids so that they are not disoriented just from not being able to know what's going on around them. And trying to get people up and moving actually seems to be very important for preventing or managing delirium. Antipsychotics are considered appropriate only for severe agitation in delirium, when symptoms pose a risk to the patient or others. And that is a statement from the American Geriatric Society, specifically looking at post-operative delirium, but it really applies across the board. There have been a number of studies looking at antipsychotics for delirium. Some show that they might help a little bit with some symptoms. They might settle somebody down. Some, in some cases, they don't look so good. And rates actually vary quite widely across different types of hospitals and health systems, which really illustrates that there's a lot of uncertainty about the right rate of use of antipsychotics for delirium. Something that gives me some pause about the use of antipsychotics in delirium, even though they've been used for many years, was a recent trial in delirium and palliative care, where they actually found worse outcomes with antipsychotics. So people were randomized to haloperidol or risperidone or placebo. They found an increased risk of mortality with haloperidol, a 1.7-fold increased risk. The risk was actually increased with risperidone as well, but it wasn't statistically significant. It was a hazard ratio of about 1.3. Both of these drugs, however, were associated with worse delirium and increased extrapyramidal side effects compared to placebo. So even though we would expect that these drugs would help reduce somebody's delirium, that would be the reason that you would use them, people are actually getting worse. It was like it was causing them to be more confused, having more difficulty with their cognition. And, you know, they are sedating medications, so it's not implausible. So that gives me, again, some pause in thinking, you know, when should we be using antipsychotics in delirium, and really thinking about trying to restrict that to the more severe cases. I actually read a paper that was titled "Things We Do for No Reason: Antipsychotics and Delirium," and so that really illustrates that the evidence is not great that they're that helpful, and we really only want to use them when we need to for safety. Delirium is also an acute disorder that resolves, and one thing that's very concerning to me is that people may get an antipsychotic for acute delirium and then be continued on that antipsychotic for a long period of time. And I've seen this happen, where 6 months later, you know, somebody had delirium for a couple days. 6 months later, there's an antipsychotic that on their drug regimen. That may be as needed, but it may also be continued chronically. And I think that would be particularly concerning in people with dementia who are at very high risk of experiencing delirium. That, you know, they're going to come back from the hospital, and maybe a nursing home or a primary care provider is going to say, well, the hospital thought they needed this drug, and so let's just leave it on. But it was really only for that acute condition. We definitely see people coming out of the hospital staying on antipsychotics for a long period of time, and I definitely suspect that delirium is an important reason for that. So it's something to pay careful attention to. And with that, we'll move into dementia, which are probably the number one reason for off-label antipsychotic prescriptions in older adults, certainly for more chronic use of antipsychotics, and definitely the most common reason that people in nursing homes get antipsychotics. Evidence does suggest that some antipsychotics have modest benefits for symptoms of dementia, different behavioral and psychological symptoms, particularly agitation. Interestingly, psychosis doesn't necessarily respond that well to antipsychotics when it's in dementia. So agitation actually seems to respond a little bit better. And I say some antipsychotics because there is variability in the studies of showing whether the antipsychotic helps or not. And I will pick on quetiapine again here, because there have been 4 randomized controlled trials of quetiapine that have essentially found that it does not work for symptoms of dementia. Nevertheless, it is one of the most commonly used antipsychotics in dementia. From an Office of Inspector General report looking at Medicare data in 2007-8, they basically found it and risperidone were the 2 predominant antipsychotics used in dementia in nursing homes. And how that can be when we have strong evidence really suggesting that it's not that helpful, I'm really not sure. Only one of those trials found a potential benefit, and that was at 200 milligrams of quetiapine a day, which is actually higher than the dose that CMS will allow for long-term use in nursing home residents with dementia. So you would potentially get cited for having, you know, too high a dose if you got up to that level where it might actually be helpful. But overall, I think it just doesn't seem to be the best drug for managing those symptoms in dementia, despite the fact that it's used very commonly. I think what happens is that people see that this is a sedating drug, and people get sedated and they stop doing the things that they were doing, and they think, well, that was a success. But that's not necessarily the type of result we're always looking for. So first-line management strategies, as with delirium really, and I think delirium causes a lot of symptoms in dementia, first-line management strategies include thorough assessment of causes and non-drug behavioral interventions. So we want to really dig in and figure out, why is the person experiencing these symptoms? Is it something with the way that people are interacting with them? Are they experiencing pain? Is there something in the environment that's causing them to be distressed? And really think about all the different things that could be causing it. Drugs also can contribute to behavioral and psychological symptoms in dementia. There is evidence that anticholinergic drugs, really probably by way of causing delirium and confusion, can lead to increased behavioral and psychological symptoms in dementia. So if we can think about all the different things that might be causing these symptoms and try to take those away, then we may be able to reduce giving or the need to give antipsychotics in the first place. The other issue here that many of you are probably aware of is that antipsychotics are associated with increased risk of mortality and stroke, and they actually have a black box warning from the FDA saying that these drugs increase mortality. They're not necessarily a good idea to be giving to people with dementia. And that has led to multiple different types of things to try to improve the care of dementia and reduce the unnecessary use of antipsychotics. Again, some of my work has really targeted that. And we have things like the CMS Partnership to Improve Dementia Care in Nursing Homes, which has set targets for reducing the use of antipsychotics in nursing homes, and many people have really rallied around that and tried to improve care, and we've seen some success in reducing those high rates that were observed in the early 2000s. So to touch a little bit more on that mortality risk, there is this black box warning that came out in 2004. The risk seems to be fairly consistent across atypical antipsychotics. There is some suggestion that there might be variability, but the numbers haven't been that high in clinical trials to tell us that one is definitely safer than another. Conventional antipsychotics, based on observational studies, may actually pose a higher risk of mortality, so switching from atypical to conventionals, as some people were doing initially when this warning came out, was not necessarily the best idea either. We see, again, an increased risk of about 1.2% mortality with antipsychotics compared to placebo, and that translates to a number needed to harm of 83. So for every 83 people we give an antipsychotic for symptoms of dementia, there may be one excess death. The number needed to treat with these drugs to actually get a response is 5 to 14, which is also not the type of number needed to treat we'd ideally like to see for a drug that has a lot of different types of side effects and can lead to a lot of problems. And this really translates into, for every 9 to 25 people that are helped by the drug, there is one death associated with use. This is not the type of risk-benefit ratio we would usually accept for different types of drugs. And I think the reason that we do sometimes accept it is because there are times when somebody is having symptoms that are very distressing, they're not safe for the person or for other people, and there gets a point where there is nothing else that can really be done. But I do think it's important to always try a lot of other things first and to try to minimize the amount of antipsychotic that we do use in people with dementia. So we saw again from that Office of Inspector General report from 2007, really chart reviews. They looked at charts and people in nursing homes and found that almost a quarter of antipsychotic prescriptions had some sort of problem per their assessment. There was an excessive dose in about 10% of cases. People were getting them for too long, again, in about 10%. Without adequate indications in almost as many cases, without adequate monitoring, which is also a major issue. Are we monitoring for the side effects that might be experienced, or monitoring for whether the drug actually seems to be helpful for somebody? And then about 5% of cases, there were adverse effects that indicated the dose should be reduced or the drug discontinued, yet people just continued to get the same dose that they were getting previously. So trying to make sure that things are monitored well, that we know the drug is helpful, that they're not getting too much, they're not getting it for too long. All these things are important things that we can do to try to reduce unnecessary antipsychotic use in people with dementia. If we look at what's happened with the initiation of the Partnership to Improve Dementia Care, which happened in about 2012, there was in fact a start toward a decline in use of antipsychotics that seemed to be happening previous to that, but the rates were upwards towards 25%. So here we see on the yellow line the national rates, and on the green line the rates in Iowa, which have pretty much mirrored the national rates and the reductions in antipsychotic use that have been observed. And we've gone from over 20% down closer to 15-16% of people in nursing homes getting antipsychotics. And that is definitely a step in the right direction. If we look at the variability, in looking at the quality measures for antipsychotic use for Iowa nursing homes, just as an example, we can see that there's still a lot of variability in the rates of antipsychotic use in these nursing homes. Most of the people that you can see in that blue box, really, the median is that black line going across the middle of the blue box. About half the nursing homes fall within that blue box. So it's roughly 10 to 20% rates in half the nursing homes. But then a good proportion of the nursing homes, another quarter, have lower rates, less than 10%. So some people are doing things that are allowing them to use fewer antipsychotics. And then there are some that have very much higher rates. So all that whisker that's going out the top is, again, where sort of most of the additional nursing homes are falling. And then we have these outliers that are up here shown by these circles. And certainly the case mix that are in these different facilities has something to do with the different rates, but we also see variability by the quality of nursing homes. And that's been established that better quality nursing homes tend to have lower antipsychotic use rates on average. So despite all the gains that have been made, we still have some room for improvement in the nursing home care. So there are many ways we can try to reduce antipsychotics. We can try to prevent the initial prescription. So we're talking about de-prescribing today, which is really about what to do once somebody's been on a medication for some time. But we also want to think about what can we do to prevent them from getting it in the first place. So we try to prevent those symptoms through providing optimal care, trying to reduce drugs that may contribute to them, and then use alternative management strategies when people do experience symptoms and try to do that without drugs. There are places that just say, we're not going to use drugs for this, figure it out. There are other ways that we can try to manage these symptoms, even though I do think there are cases certainly where the other things are not effective for people. We need to scrutinize the need to continue new prescriptions. So when something gets started, was it for delirium? Was it for some acute reaction to something going on in the environment? Just because something happens once and a person gets agitated and maybe strikes out or does something, it doesn't mean that that means that they need to be put on an antipsychotic and left on an antipsychotic continually. So if it's an acute situation that has led to the use of this, then we really want to think about, can we take that away? The American Psychiatric Association has guidelines that say if a person hasn't responded within 4 weeks, they should also be discontinued. That's definitely the case that a lot of people don't respond to an antipsychotic. And so we need to be measuring that objectively, monitoring symptoms, writing it down, and really making sure that we know and aren't just having biases about, well, they're on the drug now, they must be better. And people who have received antipsychotics for an extended period of time, we want to consider gradual dose reductions. So I've heard different recommendations around this and talked to a lot of different people about what they think is good to do. Some people would say after 1 month or maybe up to 3 months of antipsychotic use, even in someone who's responded, we should be thinking about, can we cut back this dose? Do they still need it? In dementia, again, those symptoms can respond frequently to placebo, and they can also evolve substantially over time. So even if someone benefits initially, they may not need it later. If somebody comes into a nursing home on an antipsychotic, maybe they've been on one at home because their caregiver was having a lot of burden, having a lot of challenges in providing that care. When they come into a nursing home and you have professional caregivers with 24-hour care, that might change. They may no longer need that drug as they did originally. So you want to really be thoughtful about whether that was just being used to keep them in their home and ease some of the burden on the caregiver, and that now that they're in here and they have more of this round-the-clock kind of care, whether that can be taken away. Then again, going back to the American Psychiatric Association guidelines, they recommend gradual dose reduction within the first 4 months, unless there's been some clear evidence from prior attempts to discontinue that has led to symptom recurrence and has led to problems for that patient. There are other resources I just want to highlight. I can't go really through everything about this topic today, but I do want to highlight this change package from the National Nursing Home Quality Care Collaborative, which goes through a lot of different things that nursing homes can do to try to avoid unnecessary antipsychotics in dementia. Those include designing and creating a calming environment, creating meaningful relationships, providing meaningful activities, identifying and treating physical and mental conditions, and defining a consistent approach to minimize the use of antipsychotic medications. And so that really gets to facility-level approaches. What can the facility do? Do they have a behavioral management team who tries to look at these issues, look at antipsychotic use and other psychotropic drug use, and see if it's really appropriate? Think about other strategies for managing symptoms in people. So that's a good resource that I would recommend. There are medications that we can use as alternatives to antipsychotics. We have seen some shift away from antipsychotics to other medications, sometimes not for better necessarily, in management of dementia symptoms. But in some cases, there are probably drugs that are probably safer than antipsychotics that may be helpful. Pain management, I think, is one that's particularly intriguing. I've heard some success stories from nursing homes about this. And there's also been a cluster randomized controlled trial where they randomized nursing homes to get this pain management protocol or not. And it was an empiric pain management protocol where they didn't know if people were in pain. Pain is hard to assess in people with dementia. They can't necessarily communicate it well, depending on their severity. And what they found was by starting people on these medications, in most cases actually acetaminophen, in 2/3 of cases, they saw reductions in agitation in the intervention group. And then they did a washout and found that when they stopped giving them these medications, the agitation went back up. So I really think of acetaminophen or Tylenol as a first-line treatment for agitation and dementia. If there's any reason to think that somebody might be experiencing pain, which many older adults do, have at least some kind of arthritic pain or something else, then think about trying acetaminophen, trying scheduled acetaminophen to see if that can reduce somebody's agitation and distress. The SSRI antidepressants, there have also been some studies with some of these that suggest that maybe they're almost as good as antipsychotics for managing agitation in patients with dementia. And that's probably going to vary by person, but certainly you could imagine depression and anxiety playing a role, or maybe there's some other mechanism that these drugs are leading to lower rates of agitation. It's notable that this particular trial of citalopram used a dose that now is considered too high because citalopram in particular can increase QTc intervals and cause potentially heart problems in older adults. But nevertheless, there is reason to believe that SSRIs are a decent option to consider if somebody's experiencing agitation. There are some other drugs that have come out, like dextromethorphan quinidine or Nuedexta has come out, and there has been a trial that suggested that this could be beneficial for behavioral and psychological symptoms of dementia or agitation. It's used for different sorts of suitable or affect or overexpression of emotions and things as well. Now, the quinidine part of this drug is used to inhibit cytochrome P450-2D6, which is possibly problematic because of all the different other drugs that people could be getting, including antipsychotics, and sometimes in that trial, that are metabolized by cytochrome P450-2D6. So if you inhibit their metabolism, they're going to possibly cause more side effects as well. And the dextromethorphan component can increase the risk of serotonin syndrome. There were also some adverse effect signals that were kind of waved off in the paper, but I really look at them and say this is concerning because there's reason to believe that the drug could cause these, especially falls. There was about twice the rate of falls with this drug compared to with placebo in these trials. And then there were some other side effects that were observed as well. And one thing to be aware of if you're thinking about this is that this is an extraordinarily expensive medication. Even though you might look at these and say they're both generic drugs, this new combination is patented and is very expensive. There are also other drugs people might think about using for these symptoms in dementia. Cholinesterase inhibitors are, perhaps fine to use. They do cause a lot of GI side effects and other things, but they are used for reduction of the cognitive decline in dementia, and they may actually be helpful for hallucinations in Parkinson's disease or Lewy body dementia, so they do have a place. But if you try to treat an active behavioral and psychological symptom with a cholinesterase inhibitor, you're not likely to see a lot of benefit there. Memantine, another cognitive enhancer, there was less agitation reported in the group at least agitation as a side effect as they were assessing it in this trial. There was less agitation reported in the memantine group than with placebo, so maybe there's something there. But there was also more confusion reported with that drug. So, it's coming at a cost of potentially increased confusion. Anticonvulsants, for the most part, we shouldn't be using for behavioral and psychological symptoms of dementia. There has been some mixed evidence with carbamazepine, but it's not very well tolerated, and it also causes a lot of drug interactions. It actually induces a lot of different liver enzymes, and it's hard to give with other medications. And then divalproax, or valproic acid. We've had 4 randomized controlled trials with this drug as well, showing that it doesn't work for behavioral and psychological symptoms of dementia. Despite that, people seem to have, again, shifted to that when they were trying to stop using antipsychotics. It's certainly going to be sedating, but it's also going to cause tremor and other problems, and that's not the outcome necessarily we're looking for. And one of the longer-term studies that followed people for a couple of years actually saw increased hippocampal atrophy. So the part of the brain that really is involved in memory, it was actually shrinking faster when people got this drug than when they didn't get it. So I really don't think that it's a good idea. It doesn't appear effective, and it's probably harmful. Benzodiazepines are sometimes used for dementia symptoms, and maybe for a very short-term use in acute situations. Somebody needs a medical procedure or something. They could be a reasonable choice. But for the most part, they're not recommended by experts because they worsen cognitive impairment and confusion. They can contribute to falls, and we don't really know that much about how they work because people basically decided that this isn't a very good idea to be giving these drugs to people with dementia. So there really haven't been a lot of trials that have focused on their efficacy. So the next question really is, when and how should we think about reducing or discontinuing antipsychotics in dementia? So some of the basic things we've talked about already to some degree are that we only want to continue a medication if we really think it's working, and we should also continue non-drug types of interventions regardless of whether we're continuing a medication or not. There have been studies that have taken people who have been on antipsychotics for a while, maybe a couple of years in nursing homes, and looked at what happens if we randomize people to titrate this antipsychotic down and discontinue it versus to just continue their drug as usual. And they've actually seen some benefits to reducing the antipsychotic use. Decreased depressive symptoms, for example. There was a program called an Awakenings program where they were trying to get people off antipsychotics, and there are all these anecdotes about people who just sort of woke up, and that's, thus the name, and really were much more engaged once they stopped taking these medications. In these studies of discontinuation, people who were stable long-term usually did fine getting rid of the drug. They really didn't have a lot of problems, and again, sometimes benefited. But those people with residual symptoms who were still having agitation and other problems despite the antipsychotic, there was a risk of them getting worse. So you do want to think about who are the good candidates for reducing use of antipsychotics. If we look at initial response and then what happens if you take the drug away in people who have responded, there was a randomized controlled trial of people who responded to risperidone, most of whom were in outpatient or assisted living settings, and seeing what happened if we took the drug away. I think the first important point of this trial is that only about 60% of patients responded in the first 16 weeks. So there was a healthy proportion of patients who really didn't get any better on risperidone. And in those patients, we would want to discontinue the drug just simply because it wasn't working. Then when they randomized people in a couple of different phases to stop risperidone, they did see that there was a higher relapse rate in the placebo group. But if you look at those survival curves up here, then you can see that the placebo group by 4 months out, essentially, almost half of them did not relapse. So there was, again, a proportion of these patients who did just fine discontinuing the medication, even though the relapse risk was a little bit higher. And then you saw sort of the same thing if they discontinued the drug after that second 16 weeks, that the group who stayed on risperidone had a lower relapse risk, but the placebo group, about half of them also did fine. So we know that there's a subset of patients who are going to do okay discontinuing the medication. We just have to be thoughtful about in whom we're discontinuing it, how severe were their symptoms, what might be the consequences of trying to cut back on that dose. So as I mentioned, gradual dose reductions in dementia, just as in other conditions, and perhaps even more so than in other conditions, are important to attempt. We want to try those at least twice a year, and then more quickly after an initial prescription if there is reason to believe that that person doesn't necessarily need a long-term treatment with that drug. We do have to monitor people closely, and we don't necessarily have to cut the dose super rapidly. We can just kind of take it slow and see what happens if we cut back on that drug. As I mentioned, if we used antipsychotics in delirium, there's no reason to continue them long term. We should discontinue or taper the drug after resolution. And then, how do you want to approach this? A general guideline with these medications is to think about a 25% decrease every 4 to 6 weeks or so. Again, that's not a very aggressive timeline for discontinuing the drug, but it also gives the drug time to decline and get to a new steady state, to monitor what's going on for a while. You can certainly go faster, and some people do, but I think that this kind of a pace will prevent a lot of the crises that have sometimes happened when people abruptly discontinue these drugs, just because they say we shouldn't be using these things anymore. Thinking about in a facility like a nursing home, what can be done to try to think about discontinuing medications? We could have a behavioral management team, as I mentioned, who reviews new drugs or incidents and thinks about ways to manage them. Also reviews people who have been on a drug and thinks about trying to get behind, is it time to do a gradual dose reduction? And if this recommendation comes from a team of people who are together thinking about this, instead of, for example, a pharmacist saying it's been 6 months, we got to try something, then I think you're going to get a lot more buy-in. If everyone's on board, knows what's going on, has other strategies to put in place if the drug discontinuation leads to potential problems. So that team can help support both a systematic approach to thinking about medication discontinuation, as well as possibly success of those attempts. We also want to require basic assessments before letting people call the prescriber and ask for medications. A colleague that we presented with some years ago, a geriatric psychiatrist, was talking about implementing a basic worksheet for nurses in the nursing home to say, you got to do these things before you call me. You got to take vitals, you got to look for other things that could have caused this particular symptom. You got to do a basic review of symptoms to see what kind of medical problem they might be having. And just by implementing that requirement and saying, you got to do these things before you call me, the calls, he said, dropped dramatically. So it's about doing good assessment, trying to understand what's going on, and that can really reduce these triggers that lead to people saying, we got to have a drug, we got to do something right now. Some facilities have a gatekeeper for medication requests. It says only the director of nursing, for example, can call and ask for a medication to keep those requests from coming in from other people. And then also just, again, using patient-centered approaches to care, which is a real focus of the partnership to improve dementia care and other types of things that have been tried to reduce antipsychotic use. So making sure people have activities that are meaningful to them, making sure that the institution is flexible. Are you telling people they have to get up at a certain time, they have to eat at a certain time, they have to bathe at a certain time? Those kinds of things make people upset. And one nursing home that I talked with, their leaders were telling me that, once we stopped trying to make people do stuff that they didn't want to do, we found that we really didn't need these drugs so much. So you really have to think about what is it in the environment, what it is from the institutional perspective that could be contributing to somebody's symptoms. People still want autonomy. They still want to be able to make choices. They want to sleep when they want to sleep, and so on. And so we also have to think about the environment, and are there things in the environment that could be confusing to people, that could be scary? Does the TV have some sort of scary movie on, or something else that could be disturbing to people? All of that is important for trying to reduce the unnecessary agitation and subsequent use of medications. So now I want to just briefly go through a tool that nursing homes can use or for thinking about, we want to try to do some things around gradual dose reductions. Where do we start? And that was produced by Telgen, who's been the quality improvement organization for Iowa for a number of years. And they really talked about a basic process that you can use and really said, okay, how do we take these principles and put them into action and try to get people some successes in reducing antipsychotic use. So the first thing they said was, well, make sure that the right conditions are documented. The minimum data set is used for care planning in nursing homes. It's important to understand what health conditions people have. If they have schizophrenia or something, then you want to know that and make sure you're managing that correctly and that it's also well documented. And this can also influence the quality measures that are used to look at antipsychotic use in nursing homes. They next say to consider the discontinuation of as-needed drugs. And CMS has definitely gotten behind this in saying that we have a maximum of 14 days of use of as-needed antipsychotics in nursing home residents, and then the order has to be rewritten. We don't want that drug to be there just as a crutch that for someone that doesn't want to, that is basically reacting to a situation and just wants to, sedate somebody. I've heard, talked with pharmacists who said, you can definitely tell when such and such nurse is working because everybody gets their benzodiazepine or everybody gets their as-needed medication. So we definitely want to try to avoid that kind of practice, and not allowing as-needed use of medications is one way to do that. Then they say, okay, how long has it been since we've had a failed reduction attempt in this person? And if it's been longer, then that pushes somebody up on the list of people who you might consider the next candidate for a gradual dose reduction. They don't necessarily want people to go and try to reduce everybody's medication at the same time because then it's a lot to be tracking, but trying to highlight those people who are going to have the most chance of success. And we have to ask, is it an appropriate target symptom? Really, we should only be using antipsychotics if people are having agitated or psychotic symptoms or for other types of health conditions perhaps. And that those symptoms put them at a risk or others at a risk. So if it's not an appropriate target symptom, if it's something like wandering, wandering around at night is not a reason to give somebody an antipsychotic, then we just want to think about taking that drug away because it's the wrong symptom to be targeting. Then the last step here is really to rank residents on the chance of dose reduction success. And they suggest really starting with the people with the they call them non-aggressive target symptoms. So basically, if they're not striking out or having things that are really dangerous to people, then they're the better candidates for dose reduction. And so looking at all these different issues and saying, which people are the people who are going to be most likely to be able to cut back their dose and possibly discontinue it. Another issue that is considered is whether the dose is high. So if somebody's on a very high dose or a dose even above the CMS allowable doses, then that's a good person to think about. Can we cut this back and use a lower dose? So this is a picture of that tool. I'm sure it's hard to see on the screen, but it is available from the Telgen website and has been used quite widely and with a good bit of acclaim. And it just kind of walks through these different steps. This first decision path here, again, discusses some of the things that I talked about. Is it an as-needed medication? Was there a failed attempt to make a dose reduction and other things? And if that's not true, then we move on to the second page where we can look at who the residents are, what their target symptoms are, and they suggest taking those with what they call non-aggressive target symptoms and ranking them first and saying, okay, of these people who have target symptoms that are not hitting or kicking or biting or other things that are potentially dangerous to people, how long have they been off? Has it been since we tried to reduce the dose? How long have they been free of the target symptom? Then rank them, and basically the people who have been off have had no symptoms for the longest, and the people on the higher doses, and the people who have been on the medication for the longest time. You look at all these and see who gets to the top of the list for someone who may have a successful gradual dose reduction, whether or not that means discontinuing their antipsychotic and starting there. So I recommend looking at this and trying to implement it if you have not done so. The last thing I want to plug today is that we actually have a more comprehensive program to talk about antipsychotic use in dementia and the management of, really more broadly, the management of behavioral and psychological symptoms of dementia. So the IA-ADAPT, Improving Antipsychotic Appropriateness in Dementia Patients program you can find on the IGC website. It's actually in the blue bar above on the website. You can click on that and please feel free to explore that. We've developed a number of decision aids around assessment and management of symptoms, as well as monitoring of antipsychotic side effects and other things. These come along with evidence reviews that you can go and read and understand the evidence behind those decision aids, as well as now we have even if you went to this website before, now we have an Ask the Experts section, which is the result of some outreach we did in a number of rural Iowa counties, asking providers, what is it that would be helpful to you to understand better about care of dementia? And we created some evidence summaries, 40 plus evidence summaries in response to these questions, vetted them with stakeholders, and so I hope that this information could be helpful to you if you spend a lot of time managing symptoms of patients with dementia. So thanks for listening to the lecture today. I hope that this series has been interesting and useful to you. Just to summarize my talk today, most antipsychotics in older adults are used off-label and in conditions where benefits could be questioned. So there is a lot of room to be thinking about, is this the right drug for this person? Should we be considering de-prescribing this medication? And that again is because the side effects of these drugs are both common and significant and become more frequent and potentially more severe as people get older and they can tolerate, don't tolerate these drugs as well. And gradual dose reductions generally should be considered to minimize those adverse effects and unnecessary use. And that can even extend to the on-label conditions like schizophrenia, where we do have some evidence that a lot of people are maybe on a little bit higher dose than they necessarily need to be on. And if we reduce that, then we might be able to alleviate some of their side effects. So again, thanks for being here today and listening. And I hope this information was helpful to you. And we'll look forward to next year's geriatric lecture series. Take care.